Thank you. Good afternoon, ladies and gentlemen. My name is Yusuke Saitoh, and I came from Japan, north part of Japan, Hokkaido Island, located at the center of the Hokkaido Island, Asahiko City, very cold area in the winter time. It is my great pleasure and an honor to present my paper. What I'd like to talk today is about endoscopic diagnosis and treatment for early colorectal carcinomas, including recent advancement and challenges. However, the mortality numbers of the colorectal carcinomas has plateaued or shown a slight decrease since 1995. Colorectal cancer death is still the third in the male and the first cause in the female of the cancer death in Japan. Early colorectal carcinoma is defined as a region confined to the mucosal or submucosal layer, regardless of lymph node metastasis. Macroscopic classification of early colorectal carcinoma is demonstrated. Easily detectable polypoid type is divided to pedunculated and sessile type, and hard to detectable flattened depressed type is divided to flat elevated 2A, slightly depressed 2C, and flat elevated with depression 2A plus 2C. Submucosal cancers is divided into three subtypes according to the degree of cancer extension. T1A, SM1 is submucosal cancer. The submucosal cancer invasion distance is less than 1,000 micrometer. T1B, SM2 and 3 are submucosal cancer. The submucosal invasion distance is 1,000 micrometer or more. This classification is very important because these invasion depths that determine the choice of therapy. This shows the incidence of lymphatic, venous permeation, and lymph node metastasis in each invasion depth from operated cases in our hospital. As you can see, intramucosal cancer TIS and T1A SM1 cancer have no lymph node metastasis. However, T1B, SM2 and 3 cancer have about 13% of lymph node metastasis. So, if the region is diagnosed as adenoma, TIS or T1A, SM1 cancer, it can be resected by endoscopy alone. However, if the region is diagnosed as a T1B, SM2 or 3 cancer, it should be resected by surgery. Next, I'd like to talk about the detection of early colorectal carcinomas. Among early colorectal carcinomas, polypoid-type cancers are easily detectable. On the other hand, it is reported that detection of F1D lesion is difficult by routine colonoscopy because these regions appear only mucosal obscure findings, such as faint redness, a few vascular abnormalities, or slight deformity over the colonic lumen. In order to detect the F1D lesions, it is essential to perform chromoendoscopy using 0.1% indigo carmine dye spray. Using this technique, precise description of observed lesions can be easily made. This is a representative case of a flat region in the sigmoid colon by routine colonoscopy. You can see only faint redness without capillary transparency. Sorry. Just a moment, please. Without dye spray, detection of the lesion is difficult. And after dye spray, indigo carmine, depression surface is clearly delineated and the lesion can be diagnosed as a slightly depressed type 2C lesion. This lesion was resected by EMR and histologically diagnosed as a focally extended submucosal T1A cancer. This shows the effectiveness of dye spray. 85% of polypoid lesions were detected without a dye spray. On the contrary, 62% of flattened depressed lesion can be detected only after dye spray. So, chromoendoscopy using indigo carmine is essential for the detection and precise evaluation of F1D early carcinomas. Next, I'd like to talk about assessment of invasion depth. This shows the therapeutic strategy of clinical TISM and clinical T1 SM carcinomas according to Japanese Society for Cancer of the Colon and Rectum guidelines for the treatment of colorectal cancer 2014. If the region is diagnosed as a TIS or T1A carcinomas and is assessed possible endoscopic unblocked resection, endoscopic resection will be proceeded, and assessed impossible en-bloc endoscopic resection, the region will be surgically resected. If the region is diagnosed as a T1B carcinomas, it should be treated by surgical resection. This slide shows the suggestive endoscopic findings of polypoid type T1B carcinomas. Expansion appearance like submucosal tumor, endoscopic stiffness, irregular surface, coarseness of the surface, converging folds toward the tumor. Deformity of the lumen is significantly higher appeared in the T1B carcinomas than in TIS and T1A carcinomas. Representative endoscopic findings are shown in the slide. Expansion appearance is tumor expansion like submucosal tumor shown in the left upper. Endoscopic stiffness, uneven surface are shown in the right upper. Converging folds toward the tumor and the stiffness of the lumen are shown in the lower. In the flattened debris type T1B carcinomas, in addition to the colonoscopic findings that appeared in polypoid type T1B carcinomas, another several colonoscopic findings were more frequently appeared in T1B carcinomas than in TIS and T1A carcinomas. Expansion appearance, stiffness, converging folds toward the tumor are demonstrated in the upper. Deep and uneven depression surface and strong redness are shown in the lower. Protrusion in the depression surface, wall deformity are shown in the upper. Wall deformity, converging folds toward the tumor, table-like elevation are demonstrated in the lower. If there is no colonoscopic findings, endoscopic resection can be performed. And if at least one or more colonoscopic findings are detected, surgical resection should be considered. Next, move on to the NBI system for the invasion depth diagnosis. Narrowband imaging system has been widely used. To tell the truth, I do not know exact mechanisms of narrowband imaging system because I was very poor at physics in my school days. Shortly speaking, conventional red, green, and blue filter were changed to spectral narrowband filters. Short wavelengths of visible blue light can penetrate only superficial area of the tissue, and blue light with 415 nanometers special NV filter is absorbed well by hemoglobin so that the superficial capillary structure can be observed using NVI system. Using NVI, various type of microvessel on the surface structure can be observed. You can see the regular microvessel pattern that with adenoma in the left side. Mild degree irregular shaped microvessel pattern that with the TIS is demonstrated in the center. And high degree irregular shaped pattern with some vascular area that with the T1B cancer is shown in the right side. Like these cases, microvessel pattern is different in each histology. Sessile region with 12 mm was detected in the rectum. You can see the type 5 irregular pattern by using magnifying colonoscopy and chromoendoscopy in the lower left. Using NVI with magnification, irregular shaped microvessel pattern is observed. This region was resected by EMR and histologically diagnosed as a TIS. This is a sessile with depression 10 mm size in the sigmoid column. By NBI magnification, high degree of irregular shaped with a spotty avascular area was demonstrated. This region is surgically operated and histologically diagnosed as a T1B carcinoma. NVI microvessel and surface pattern classification is shown in this slide. A type is a hyperplastic pattern that microvessel is not visualized. B type is adenomatous pattern that microvessel pattern is regularly arranged surrounding crypts. And C type is cancerous pattern that with irregular shaped microvessel is observed. Cancerous pattern is divided to 3 subtypes. C1 is irregular shaped reticular structure with slightly unclear glandular structure. C2 is irregular shaped reticular structure with unclear glandular structure. C3 is unclear glandular structure and a vascular area was appeared. This slide shows the comparison of NVI classification and the histological pattern. 85% of A pattern was a hyperplastic polyp. 81% of B-type were adenomatous and 19% were TIS. 44% of C1-type adenomas, 38% was TIS, and 6% were the T1A carcinomas, and 12% was T1B carcinomas. 88% of C1 type can be resected by endoscopy. On the contrary, 30 regions of C2 and T3 were T1B carcinomas, and the most regions were resected by surgery. Using this classification, invasion depth diagnosis without cloma endoscopy was made, and the therapeutic strategy can be determined. High-frequency ultrasound probe, HFUP, is also useful for the precise invasion depth diagnosis. Layered structure of the normal colonic wall visualized by 20 MHz HFUP is demonstrated. Normal colonic wall could be visualized as a 9-layered structure. The first to the third layer, mucosal layer. The fourth string low echoic layer corresponded to muscularis mucosa. The fifth layer is submucosal layer. The sixth to the eighth layer, muscularis propria. The ninth layer corresponds to subserosal and serosa. HFUP images in each invasion depth are demonstrated. Left upper is TIS, that muscularis mucosa is visualized beneath the lesion. Center and the right side are T1A cancers, that low echoic cancers invaded into the submucosa with a little amount. Lower left is T1B, SM2 cancers, that cancer invaded into the submucosal layer with moderate amount. Center is T1B, SM3 cancers, that cancer invaded into the submucosal layer massively. And HFUP can discriminate the T2 proper muscle cancer from T1 cancer, like lower right case. This sessile type polypoid region was detected in the sigmoid colon with a size of 15 mm. HFUP delineate the cystically dilated cancer glands invaded into the submucosal layer massively. Low echoic area embedded into the submucosal layer massively. And post-operative specimen was histologically diagnosed as a massively extended submucosal cancer with cystic dilatation of the cancer glands as HFUP delineated. Invasion depth diagnosis by HFUP for the therapeutic strategy is demonstrated. 89% of high overall accuracy rate was obtained by HFUP. If the region was suspected T1 carcinoma, but invasion depth diagnosis was uncertain by using cloma endoscopy or NBI, additional HFUP will be helpful. Next, I'd like to talk about endoscopic therapy for early colorectal carcinomas. There are 3 endoscopic resection methods. These are endoscopic polypectomy for the polypoid type carcinomas, endoscopic mucosal resection EMR for flat and debris type carcinomas, and endoscopic submucosal dissection ESD for large flat type carcinomas. In case of bleeding after polypectomy, even with use epinephrine injection, using clip devices, hemostasis is easily obtained. And we should also familiar with the use of loop snare. Before resection, loop snare put on the polyp base, polypectomy was accomplished safely without bleeding. This is a slightly debris type early cancer with the size of only 5 mm in size. In the descending colon, and before dye spray, the region looks obscure. And after indiocarmine dye spray, the cancer was clearly delineated in the margin of the region. Following the submucosal injection, we prefer hyaluronic acid to physiological saline. The region was lifted enough for the EMR. Wiring, cutting, and correcting the lesion using a correcting forceps. And this case was histologically diagnosed as a T1A SM1 cancer. EMR is a very useful therapeutic method. However, this is a potential disadvantage in EMR. This slide shows the comparison of unblocked resection rate and the lesion size. Unblocked resection rate is mostly satisfactory in the regions with less than 20 mm. On the contrary, unblocked resection rate is only 40% in the region with 20 mm or more. Endoscopic submucosal dissection (ESD) technique have been introduced for colorectal regions. ESD is good treatment technique without limitation of the region's size. We prefer these two kinds of knives, flash knife ball tip and IT knife 2 nano for colorectal ESD. Indication of ESD for colorectal tumor is shown in the slide. ESD is indicated for the region that is difficult to resect unblockly by conventional EMR, especially laterally spreading tumor, non-granular type, the cancer with 5 irregular type surface structure, T1A carcinoma, large Deborah's type region, and intramucosal tumor with submucosal fibrosis, and local residual early carcinoma after endoscopic resection. I will show you some ESD data in an institution. A total 229 colonic regions have been resected by ESD, and the average tumor size was 26.3 mm, max 90 mm. 177 carcinomas and 39 lesions were T1 carcinomas. Macroscopic unblocked resection rate was 98.7%, and the histological unblocked resection rate, that is to say, negative horizontal and vertical margin, was 91.7%. Treatment time was relatively long, of 63.4 minutes in average. Complications of our ESD are demonstrated. Emergency operation is relatively high in chronic ESD, but the incidence of all complications were not significant difference compared with esophageal and gastric ESD. Brand new ESD case about 50 mm flat rectal region is demonstrated. This region is identified by NBI observation and endoscopically diagnosed as a TIS. After submucosal injection of hyaluronic acid, lesion was lifted enough, and circumferential cut around the region proceeded. This is a circumferential cut procedure from the oral, anal side. And next, submucosal dissection was proceeded. It is very important to dissect just above the proper muscle layer, deep part of the submucosal layer. And in the rectal region, there are a lot of big vessels, so it is very important to prevent bleeding with using coagulation or something. Now dissecting. Almost done. Very shortening, but so actual time was about 70 minutes or something. That finished. About 50 mm region was completely resected by ESD. And the size of the resected specimen was 50 and 46 mm, well-differentiated intramucosal adenocarcinoma, TIS. Some complications may be occurred by endoscopic resection. The incidence of bleeding in conventional polypectomy is reported about 1 to 2%, 0.7% in EMR, less than polypectomy, and 1.5% in ESD. In ESD, most bleeding are delayed bleeding. In polypectomy and EMR, immediate bleeding occurred by insufficient cautery, and delayed bleeding occurred by excessive cautery. In ESD procedure, immediate bleeding occurred by cut large vessel, especially in the rectum, and delayed bleeding occurred from the vessel remnant in the ulcer bed. This is a 40 millimeter region in the ascending colon. For large flat region like this case, unblocked resection is very difficult by conventional EMR. This is a relatively old case, and piecemeal resection was performed, and during the resection, immediate arterial bleeding was occurred. Hemostasis could be obtained using some hemogryphs. Oh, sorry. Arterial bleeding during the ESD procedure was occurred in the rectal region. And the most important thing is, so we have to identify the bleeding point. And if we can identify the bleeding point, this case was burning by burning forceps. And hemostasis was obtained. And next, we use some hemogryphs to obtain a complete hemostasis. And the most serious complication of endoscopic treatment is perforation. The incidence of perforation in EMR and polypectomy is reported about 0.67% and high rate of 5 to 6% in ESD. Cause of perforation of EMR and polypectomy is burning injury of the proper muscle layer or snaring and cutting of the proper muscle layer. The same cause for perforation also in ESD. Accessory region in the sigmoid colon, we performed the ESD. And during the ESD procedure, especially in the dissection procedure, perforation was occurred. You can see a yellow area, that was a perforation site. And actually, in this case, so ESD procedure was almost finished, and a small region was attached with the rectum. So we changed to ESD procedure to polypectomy procedure. And after complete resection of the lesion, we tried to close the perforation site using some hemogryphs. Yellow site is a perforation site, and using multiple hemogryphs, we try to close. In this patient, closure of the perforation site was successfully proceeded, and the patient was discharged without any other complication. Next, move on to the therapeutic strategy for T1 carcinomas after endoscopic resection. This slide shows the Japanese Society for Cancer of the Colon and the Rectum guideline for the treatment of colorectal cancer 2014. After endoscopic resection of T1 carcinoma, if the lesion is diagnosed as a positive vertical margin, the patient should be required additional surgery. And the lesion is diagnosed as a negative vertical margin. Other than favorable or unfavorable histological type, submucosal invasion distance of less than 1,000 micrometer or 1,000 micrometer or more is evaluated. When resected lesion was diagnosed as less than 1,000 micrometer of submucosal invasion distance without any other unfavorable histological factors, it can be followed up. But when the lesion was diagnosed as 1,000 micrometer or more of submucosal invasion distance, additional surgery should be considered. Vessel permeation is also an important risk factor for the lymph node metastasis. Vessel permeation is demonstrated in this slide. lymphatic permeation should be evaluated with D240 immunostain, and venous permeation should be diagnosed with a Victoria Blue 8E double stain. When the vessel permeation was detected, additional surgery should be considered. Tumor budding is also an important risk factor for the lymph node metastasis. Budding is defined as 1 or less than 5 cancer cells cluster at the invasion front. When the lesion was diagnosed as budding grade 2 or 3, more than 5 budding in one visual field, additional surgery should be considered. After these histological findings were evaluated, follow-up or consider additional surgery will be determined on a case-by-case bias, that is to say, patient's general condition or systemic complications. As for the prognosis of endoscopically resected T1 colorectal carcinomas, we investigated 5 retrospective studies in the Japanese literature that were presented with sufficient data on the long-term prognosis of the patients. The incidence of relapse after endoscopic resection without additional surgery for T1 carcinomas was about low of 3.4%, 44 out of 1,312 cases. On the other hand, of 134 relapsed cases, 72 cases, 54%, resulted in cancer death. While the relapse ratio was relatively low after endoscopic resection, once relapse has occurred, the prognosis was very poor even in T1 carcinomas. Finally, I'd like to talk about the feasibility of endoscopic resection for T1B carcinomas as a total excisional biopsy. Lymph node metastasis occurs in about 15% of submucosal invasive T1 carcinomas. Conversely, more than 80% of T1 carcinomas has no lymph node metastasis, and a lot of unnecessary additional surgeries proceeded now. At the growth of aging population, the number of the patient will be increased, who is impossible for surgical operation by systemic complications. So, decrease of unnecessary additional surgery will be a very important issue from now on. Nakadoi et al. Reported that in the absence of any factors of unfavorable histological grade, vessel permeation, or grade 2 or 3 tumor budding, lymph node metastasis occur in only about 1.2% of T1 carcinomas of any submucosal invasion depth. Similarly, Ajioko et al. Also presented the same result of 1.4% of lymph node metastasis in T1 carcinomas of any submucosal distance without other histological unfavorable factors from 2,486 surgically operated T1 carcinomas. Among T1B carcinomas, SM3 lesion might be contact with proper muscle layer and will be likely to become a positive deep cut margin. However, endoscopic treatment can be feasible as a total excisional biopsy for T1B SM2 lesions, which have some submucosal space between cancer invasion front and the proper muscle layer, and can be dissected by ESD. In order to decrease unnecessary additional surgery, discrimination between SM2 and 3 will be important. Submucosal invasion distance can be measured preoperatively by HFUP, and measured submucosal invasion distance on the HFUP images were correlated well with those measured in the resected specimen. And HFUP can visualize submucosal space between cancer invasion front and the proper muscle layer. So, if submucosal space were visualized using HFUP before treatment, the lesion can be resected at a total excisional biopsy with negative vertical margin by ESD. Like these, HFUP will be an essential pre-therapeutic diagnosis device whether detected T1B carcinoma can be resected by endoscopy with negative vertical margin or not, as a total excisional biopsy. After complete resection with negative vertical margin, histological evaluation that mentioned above will be performed, and determine the risk of lymph node metastasis, and finally decided whether additional surgery should be performed or not, and follow up by considering patient systemic conditions. In conclusion, In the diagnosis and treatment of early colorectal carcinomas, invasion depth diagnosis with combination use of indigo carmine dye spray, NBI, and HFLP are important for the precise therapeutic strategies. Proper use of endoscopic polypectomy, EMR, and ESD, depend on the size and the shape of the lesion, is essential. JSCCR guideline for the treatment of colorectal cancer 2014 is evaluated to validate in Japan. The incidence of relapse after endoscopic resection for T1 SM1 carcinomas were relatively low, as 3.4%. On the other hand, 54% relapsed cases resulted in cancer death. HFUP will be an essential pre-therapeutic diagnostic device whether detected T1B carcinoma can be resected with negative vertical margin or not by ESD as a total excisional biopsy. Thank you very much for your kind attention. Thank you.
Thank you very much for this very nice presentation, very interesting. I don't know if anybody has questions. If not, maybe I have a question for you. So, is this ultrasound technique used on a regular basis in Japan?
Actually, so in Japan, the problem of reimbursement, so not so widely used. Okay. And actually, so HFU was widely used in late of 1990s. And but probably from now on, as I mentioned in the presentation, so invasive T1B cancer, it is whether endoscopically diagnosed completely or vertical margin was positive. It is very important. So probably using HFUP, we can correctly discriminate between SM2 and 3 cancers.
Okay, and how long does this lengthen the procedure, basically?
Just 5 or 6 minutes or something.
Okay, so it's fairly quick. And just one more question, maybe: is there a dye which is you think is more specific for these lesions, more than another one? Is it like, and you use indigo carmine?
Yeah.
But would methylene blue be better, or is there any dye which is more specific in that respect, or not particularly?
Indigo carmine is not harmful, but methylene blue is something toxicity was reported for the nuclear. So we use indigo carmine with not toxic.
Okay, thank you very much.